Hi everyone. We will be presenting a case report on recurrent hospitalization of Group B strep bacteremia with associated meningitis and osteomyelitis in a 1-month-old infant. Some background on this topic. In a typical case of Group B strep in the neonatal period, an infant will present with either an early onset or late onset infection with one main sequela of that infection. Common presentations of early onset GBS infections in the neonatal period are sepsis, meningitis, and pneumonia, and common manifestations of late onset GBS include bacteremia, meningitis, and osteomyelitis.
Today, we are presenting a very unique case of GBS bacteremia in a 35-day-old infant born to a GBS negative mother with associated meningitis and osteomyelitis. Gestation was complicated by fetal ascites in the 3rd trimester. However, this resolved spontaneously prior to delivery, and there were no other known complications. Patient first presented with GBS bacteremia on day 10 of life and received an appropriate course of antibiotics with full resolution of symptoms. The patient then returned 24 days later with suspected GBS meningitis and was again started on systemic antibiotics. During the hospital course, physical examination was concerning for osteomyelitis of the left glenohumeral joint, which was confirmed on X-ray. The lower image is a radiograph of the left upper extremity displaying a well-defined bony lucency and sclerosis of the left proximal humeral metaphysis concerning for osteomyelitis and septic arthritis. The patient was started on IV ampicillin, cefotaxime, and acyclovir, and drainage of the glenohumeral joint was performed. Antibiotics were continued at meningitic dosages for 14 days before stepping down to osteomyelitic dosages for the remaining 14 days. Following treatment, there was complete resolution of the patient's symptoms, and repeat imaging did not reveal any continued meningitis or osteomyelitis. This patient's infection was originally believed to be a recurrence following complete remission, but is most likely due to seeding of the patient's humerus with GBS during the original bacteremia. The above table lists antibiotic management of GBS-related sequelae, and as can be seen, the antibiotic regimen the patient received for bacteremia would not have been sufficient to treat any seeded osteomyelitis.
So in conclusion, we advise that any infant with bacteremia treated with antibiotics, regardless of course length, be screened for underlying osteomyelitis with a careful examination of history and physical exam prior to discharge. History gathered must include recent trauma, environmental exposure, underlying conditions, or recent illnesses, such as a recent history of bacteremia, as in this case, in this patient. Antibiotic doses should be adjusted accordingly if other infectious processes are present. If any of the previous risk factors are positive, a physical exam is needed to rule out osteomyelitis and should be conducted with emphasis placed on musculoskeletal assessment. To our knowledge, no other study has reported 2 late-onset disease sequelae of a late-onset GBS infection, including meningitis and osteomyelitis, in an infant who had recovered from a prior GBS bacteremia. Thanks for listening.